Anand, it is 4 o'clock.
Yes, sir. Good afternoon.
Hello, Payal. Good afternoon. Good afternoon to everybody. Now, we are going to finish this second week of short certificate course. And in today's program, it is a clinical medicine class. I can see attendance is a bit little less because most of us don't like to read clinical medicine because we are expert in that one, which is not a good thing. Clinical medicine is the medicine which is the first step in the diagnosis and for correct management. So today we are going to take gastroenterology, especially ascites, and Dr. Payal is here to say about this ascites, various causes and its implication. Dr. Payal, please.
Thank you, sir. And a very warm good evening to all, and to all the faculty and the residents who are here. And I'm grateful to Sir and Dr. Anupam Prakash for taking me into this program. And it's a great initiative. Today, I will be discussing about ascites particularly. And before that, I will just want to tell you the importance of diagnosing any abdominal swelling. So abdominal swelling is important because it can be a symptom of a wide range of the underlying conditions. It can be a benign manifestation of simple digestive issue, or otherwise it can be a manifestation of a very potentially life-threatening condition, which can be a cirrhosis, which can be a malignancy. So diagnosing it accurately and identifying the cause allows us to do the appropriate treatment and management of the person. So I will just share my PPT now.
Yeah.
Sir, is it visible?
Yes, it is.
Okay, sir.
It's fine.
Yes, sir. So the objectives of today's lecture will be identifying the etiology of abdominal swelling, particularly ascites, reviewing the workup of a patient with ascites, and outline the treatment and management options available. The causes of abdominal swelling can be remembered conveniently as the 6 Fs, which can be flatus, which can be fat, fluid, fetus, feces, and fetal growth. Flatus abdominal swelling may be the result of increased intestinal gas, which is mostly because of aerophagia, which is swallowing of the air. And it can result in an increased amount of oxygen and nitrogen in the small intestine and lead to abdominal swelling. So we have many patients which come to us that I am having abdominal distension, it is gaseous distension. Sometimes it may be flatus, but we should not stop at that point, taking into account what patient is presenting to us. So aerophagia typically results from gulping of the food, chewing gums, and smoking, and also as a response of anxiety. Bacterial metabolism of excess fermentable substances such as lactose and oligosaccharides also can lead to production of hydrogen, carbon dioxide, or methane in the intestine. Then fat, we know that obesity is a pandemic. So weight gain with an increase in abdominal fat can result in an increase in abdominal gut, and which can be perceived again as an abdominal swelling. This abdominal fat is caused by an imbalance between the calorie intake and the energy expenditure, which is associated with a poor diet and sedentary lifestyle. It is also a manifestation of certain diseases such as Cushing syndrome. So certain endocrine disorders and the sedentary lifestyle can lead to the fat accumulation. Fetus in pregnancy, when up till the 12 to 14 weeks of gestation, when the uterus is an pelvic organ, but after that it becomes an abdominal organ and it results in increase in abdominal girth. Feces, In the setting of severe constipation or intestinal obstruction, increased stool in the colon can lead to increased abdominal girth. These conditions are often accompanied by abdominal discomfort or pain, nausea, vomiting, and can be easily diagnosed by the imaging studies. Then comes the fetal growth. So as the name indicates, fetal is really the conditions which are difficult to treat, such as neoplasms, abscesses, and cysts, which can grow to various sizes and lead to increased abdominal girth. Enlargement of the intra-abdominal organs such as liver and spleen can also be perceived as an abdominal swelling. And sometimes an abdominal aortic aneurysm can result in abdominal distension. Some of the patients may present as bladder distension, which can be in cases of spinal shock and autonomic neuropathy. So now we come to ascites. What is ascites? Ascites is a word which has been taken from a Greek word, which is ascos, that is bag-like. So ascites is a pathological accumulation of fluid within the peritoneal cavity. It is a common clinical finding with a wide range of causes, but develops most frequently as a part of decompensation of previously asymptomatic chronic liver disease. So cirrhosis, chronic liver disease, is the most common cause of the ascites, but there are other causes also. So we come to the etiology of ascites, which can be because of the increased hydrostatic pressure or venous hypertension. In this, the first and the foremost important cause is the cirrhosis of liver. Then other causes can be hepatic vein occlusion or outflow obstruction, commonly known as Budd-Chiari syndrome, inferior vena cava obstruction, constrictive pericarditis, and congestive heart failure. Then decreased colloid osmotic pressure, which can be seen in end-stage liver disease with poor protein synthesis, nephrotic syndrome, in which we know there is a large amount of albuminuria with protein loss, malnutrition, and protein-losing enteropathy, which all lead to decrease in albumin and hence decreased colloid osmotic pressures. Increased permeability of the peritoneal capillaries is the cause in tuberculous peritonitis, bacterial peritonitis, and malignant disease of the peritoneum. Leakage of the fluid into the peritoneal cavity can be seen in seepage of the bile. Certain conditions are there in which there can be seepage. Then there can be pancreatic ascites because of the pancreatic duct injuries. Chylous ascites, in which there is accumulation of lipid-rich lymph due to the disruption of lymphatic system, which can be secondary to trauma or obstruction. Then urine ascites. Then there are certain miscellaneous causes, which are, for example, myxedema ascites, ovarian disease, in which we used to study about Meeks syndrome, in which ovarian tumor is associated with the pleural effusion and ascites, pseudomyxoma peritonei, and chronic hemodialysis. So these were the common causes of common and some uncommon causes of ascites. Nowadays, this to distinguish between the portal hypertension and non-portal hypertension ascites is a trend. So the earlier classification of the transudative and exudative ascites is usually obsolete, and we used to preferably we use the terms of portal hypertension ascites, in which the most common causes are cirrhosis and cardiac ascites, and other causes are clubbed together in the non-portal hypertensive ascites, in which all the causes of malignant ascites, tuberculous peritonitis, pancreatic ascites are clubbed together. Then another term is the mixed ascites, in which mixed ascites is said to be when the patient with cirrhosis are having ascites and along with the secondary cause, such as superimposed tuberculous infection or bacterial infection. This table is showing us the different etiologies of ascites in developed and developing countries. So there we can see that there is a remarkable difference in the causes. The portal hypertension is the most common cause in developed countries, in which two of the most common causes are cirrhosis and cardiac ascites. And in developing countries, although the most common cause is still the cirrhosis, but there are other causes such as infections. They also play an important role in developing countries. So this is to show a variation of the etiology of ascites among developed and developing countries. Now the pathogenesis of ascites. So pathogenesis can be grouped together in the two different headings, that is in the presence of cirrhosis or in the causes in which cirrhosis is not there. So hepatic ascites in cirrhosis arises from a complex interplay of factors, primarily driven by impaired liver function, portal hypertension, vascular dysfunction, and systemic inflammation. Development of hepatic fibrosis, which defines cirrhosis. What is hepatic fibrosis? It disrupts the normal architecture of the hepatic sinusoids, and consequently there is disturbance of the normal blood flow through the liver. Secondarily, there is activation of hepatic stellate cells, which mediate fibrogenesis, which leads to smooth muscle contraction and fibrosis. Finally, cirrhosis is associated with a decrease in endothelial nitric oxide synthetase production, which results in decreased nitric oxide production, and so there is intrahepatic vasoconstriction. Increased systemic circulating levels of nitric oxide leads to splanchnic arterial vasodilatation. So in case of cirrhosis, there is intrahepatic vasoconstriction accompanied with the splanchnic arterial vasodilation. This vasodilation in splanchnic circulation results in pooling of the blood, and there is a decrease in the effective circulating blood volume, which is perceived by the kidneys as hypovolemia, and that's why there is release of antidiuretic hormone and also free water retention and activation of the sympathetic nervous system. That is renin, angiotensin, aldosterone system, which leads to sodium absorption and water retention. So finally, what we have is that there is renal sodium absorption and water retention, which leads to the ascites, that is the collection of the fluid in the peritoneal cavity, along with patients. Sometimes we have seen patients who are coming with lot of edema, and sometimes patients may not have edema. So this is because of the splanchnic vasodilatation and the renal sodium absorption. Now the pathogenesis in the absence of cirrhosis. Ascites in the absence of cirrhosis generally results from peritoneal carcinomatosis, peritoneal infections, and pancreatic diseases. Peritoneal carcinomatosis may result from primary peritoneal malignancies such as mesotheliomas or sarcomas, or other abdominal malignancies which can be gastric, colonic, or some metastatic disease. Tumor cells lining the peritoneum produce a protein-rich fluid that contributes to the development of ascites in such cases. In the tuberculous peritonitis, again the tubercles, they deposit on the peritoneum and they produce a proteinaceous fluid. So this is a pathology in the malignancy and tuberculosis. So how do we initially evaluate a patient with ascites? So with a history and a meticulous physical examination, we proceed with an imaging test and the other laboratory investigations. And finally, the diagnostic paracentesis for the analysis of the ascitic fluid is foremost important thing. Patients with ascites typically report progressive abdominal distension that can be painless or can be associated with abdominal discomfort. The time course over which this distension develops will depend upon the etiology of the ascites, because some patients will present to us with a very slowly developing ascites and they may not remember that the particular date. And some patients will tell that I have developed the ascites within a few days. So it may develop over a course of few days in cases after the trauma, such as bloody ascites, or in months in malignant ascites. Ascites due to the cirrhosis or alcohol-associated hepatitis usually develops rapidly over few weeks. Patients may also complain of weight gain, and because of the abdominal distension, patients may have shortness of breath, early satiety, and dyspnea resulting from fluid accumulation and increased abdominal pressure. Patients with cirrhosis may have other symptoms associated with hepatic decompensation, which can be confusion, which is a marker of hepatic encephalopathy, and they have evidence of gastrointestinal bleed, which can be a fresh hematemesis or LINA. Medical history includes a history of risk factors for liver disease, which we all have to take in such patients, such as history of viral hepatitis, history of alcohol consumption, metabolic syndrome, familial liver diseases or autoimmune diseases, history of heart disease in cardiac ascites, history of past tuberculosis, any travel history. They all will be an important thing to find out. In the general examination, we can get enlarged lymph nodes, which may be suggestive of tuberculosis or hematological malignancies or any other malignancies. Supraclavicular lymphadenopathy, commonly known as Virchow's node, will suggest metastatic abdominal malignancy. There can be associated jaundice, which is usually seen in patients with liver diseases. Patients can have dyspnea, paroxysmal nocturnal dyspnea, orthopnea, and pedal edema in cases of congestive heart failure. There can be elevation of jugular venous pressure. There will be elicitation of Kussmaul sign, that is elevation of JVP during inspiration, a pericardial knock, murmur of tricuspid regurgitation, which can all be appreciated and will point out towards the presence of heart failure or constrictive pericarditis. Periorbital edema, puffiness of face and edema associated with ascites point out towards acute nephritic and nephrotic syndromes. Then there can be stigmatas of chronic liver disease, which are spider angiomas, Palmer erythema, dilated superficial veins around the umbilicus, commonly known as caput medusae, and gynecomastia in a male patient. An umbilical venous hump may suggest the presence of portal hypertension in patients with hepatocellular carcinoma or alcoholic hepatitis. Abdominal swelling caused by intestinal gas can be differentiated from a swelling which is caused by the fluid or solid mass by percussion. In cases of intestinal gaseous distension, there will be tympanic node. But if there is a fluid or there is a mass, it will be dull on percussion. The absence of abdominal dullness, however, doesn't exclude ascites, because it is said that a minimum of 1500 ml of the ascitic fluid is required for the detection of physical examination. So, sometimes the flank dullness or shifting dullness may not be there, and still it may there is ascites. Patients may also have shifting dullness, which is a change in the location of dullness to percussion when the patient is turned due to the movement of the ascites, and it is an important sign which every undergraduate student is usually taught in the wards. Finally, the abdomen should be palpated to assess for tenderness, presence of any mass, enlargement of spleen, liver, or presence of a nodular liver, which will suggest cirrhosis or tumor. Sometimes pleural effusions may also be present with the ascites, in which case the right effusion is usually greater than the left effusion. Pleural effusions are manifested by decreased breath sounds or dullness to percussion. A grading system for ascites has been proposed by the International Ascites Club, in which grade 1 ascites is mild ascites, which is only detectable by the ultrasound examination. Grade 2 is moderate ascites, which is manifested by moderate symmetrical distension of the abdomen. And the grade 3 is the large or the gross ascites with marked abdominal distension. After the history and the clinical examination, we have imaging investigations in which abdominal ultrasonography is the most commonly used non-invasive test. It can detect as little as 100 ml of the ascitic fluid. And also, apart from the ascitic fluid, it can also comment on hepatosplenomegaly, nodular liver, presence of any mass. Dilatation of the portal vein can be seen in ultrasound, and dilation of splenic and superior mesenteric veins can also be seen. Ultrasonography is often inadequate to detect retroperitoneal lymphadenopathy or a pancreatic lesion, and that is because of the overlying bowel gas. If malignancy or pancreatic disease is suspected, CT scan of the abdomen is preferred. CT scan may also detect changes associated with advanced cirrhosis and portal hypertension, but usually we don't do it as an initial test. Hepatic, adrenal, splenic, or lymph node lesions associated with masses arising from the gut, ovary, or pancreas are suggestive of the malignant ascites in seen on the CT scan. Now we come to laboratory investigations. Liver biochemical testing. A full range of the liver function tests will be done, in which we can see the serum total bilirubin, direct and indirect indices. Serum albumin level measurement can be done. Prothrombin time determination along with international normalized ratio, that is INR, to assess the hepatic function. Then complete blood count to evaluate the presence of cytopenias. Usually the patients with portal hypertension may have anemias, may have thrombocytopenias. Patients with cirrhosis may also have elevated INR. Patients with cirrhosis have hypoalbuminemia, thrombocytopenia, anemia, and leukopenia. So there can be a wide range of the abnormalities which can be seen in the complete blood count and liver function test in such patients. Serum amylase, serum lipase levels should be checked to evaluate the patient for acute pancreatitis. Urine protein quantitation is indicated when nephrotic syndrome is suspected. Then abdominal paracentesis. Abdominal paracentesis is the test which we perform to take out the ascitic fluid for the ascitic fluid analysis. It is one of the most rapid and cost-effective method of diagnosing the cause of ascites. It is a bedside procedure in which a needle or a small catheter is passed transcutaneously to extract ascitic fluid from the peritoneum. The lower quadrants are the most frequent sites for paracentesis, and left lower abdomen is preferred because of the greater depth of the ascites and thinner abdominal wall on this side. The ascitic fluid which has been taken out should be sent for measurement of the albumin and total protein levels in it. Then cell counts, differential count should be done. And if infection is suspected, gram staining and culture with inoculation into the blood culture bottles at the patient bedside itself should be done. And it is done to maximize the yield. A serum albumin level should be measured simultaneously to permit the calculation of the SAD, that is serum ascites albumin gradient. Additional tests that can be performed in ascitic fluid for confirming a diagnosis may include glucose concentration, which may be important in malignancies, infections, and bowel perforations. Lactate dehydrogenase concentration in malignancies, infection, and bowel perforation again. Then serum amylase levels of the ascitic fluid will be important in pancreatic ascites or bowel perforation. Tuberculosis smear, culture, and ADA, that is adenosine deaminase activity in the ascitic fluid will be seen in tuberculous peritonitis. Then cytology, cell count, and looking for a malignant cells can be seen in cases of malignancy. Then triglyceride levels in the ascitic fluid will be high in cases of chylous ascites. Bilirubin concentration, bilirubin can be there in cases of biliary perforations. Then in heart failure, there can be elevation in the pro-brain natriuretic peptide in ascitic fluid also. So apart from doing a cell count and the level of the albumin in the ascitic fluid, other investigations can also be advised depending upon the differential diagnosis. Now we come to the initial ascitic fluid analysis, that is the gross appearance of the ascitic fluid. The initial evaluation also gives us certain diagnostic informations. In uncomplicated cirrhotic ascites, the fluid is usually clear and light yellow, which is known as straw-colored ascitic fluid. Then the ascitic fluid can be cloudy, it can be turbid, usually seen in bacterial infections, pancreatitis, or gastrointestinal perforations. Blood tinge or the bloody fluid can be seen in malignancies, hemorrhagic pancreatitis, and intestinal infarctions. Now here there is a point that because of the insertion of the needle, sometimes there can be trauma to the blood vessel, which can also lead to the bloody fluid. So that we have to see that whether it is homogeneously mixed with the ascitic fluid or it is coming in the initial few drops. Milk-like chylous ascites is generally due to the presence of a large amount of triglyceride in the fluid, and it can result from lymphatic disruption that may occur in trauma, cirrhosis, tumors, tuberculosis, or congenital anomalies. Dark brown fluid can reflect a high bilirubin concentration and will indicate a biliary tract perforation. So this was the importance of the gross appearance, how the ascitic fluid initially looks when it is taken out, and it can also give us important clues about the diagnosis. Then ascitic fluid total protein concentration. Traditionally, ascites is classified into broad categories of transudate or exudate according to the total protein in the ascitic fluid. And we used to quantify it as the ascitic fluid total protein more than 25 gram per liter and less than 25 gram per liter. So, but now this division of the transudate in exudate is considered outmoded and flawed. And with the introduction of the SAG, that is the serum ascites albumin gradient, this is now considered the best single test for classifying ascites into the portal hypertensive ascites, which is the SAG more than 1.1 gram per deciliter, and non-portal hypertensive, that is less than 1.1. It is calculated, its calculation is very simple, calculated by subtracting the ascitic fluid albumin value from the serum albumin value. The accuracy of this test is approximately 97%, and a multi-center prospective research demonstrated that the SAG in portal and non-portal hypertension concept was superior to exudate and transudate concept. So nowadays we have been using this SAG only. So it is recognized as a reliable marker in the differentiation of portal hypertension and non-portal hypertension ascites. The most common causes in the portal hypertension, as we have already discussed, will be the cirrhotic ascites and the cardiac ascites. And in the cases of non-portal hypertension, these are the peritoneal carcinomatosis, tuberculous peritonitis, and nephrotic syndrome. Polymorphonuclear cell count and bacterial culture have been used in the diagnosis of infected ascites, and a term which we have been using is spontaneous bacterial peritonitis. What is spontaneous bacterial peritonitis? It is the presence of cell count of mainly the polymorphonuclear cells, more than 250 cells per millimeter cube in ascitic fluid, with or without a positive bacterial culture. And also there is absence of any intra-abdominal source of infection. That is, there should not be any perforation. So the most common pathogens in cases of spontaneous bacterial peritonitis are gram-negative rods, E. coli and Klebsiella, and sometimes it can be gram-positive cocci also. What is secondary bacterial peritonitis? It is defined as the presence of the ascitic fluid neutrophil count of same, that is the greater than 250 cells, but there should be peritoneal free air on the radiography or CT, or perforation of a intestinal wall, which is demonstrated at the time of surgery. So in cases of the cirrhosis, we are mainly concerned about the spontaneous bacterial peritonitis. So any patient who is having ascites, who presents to us with new onset fever, abdominal pain, should always be investigated for the presence of spontaneous bacterial peritonitis, and starting a broad spectrum antibiotics such as the cefotaxime will be is important in whenever we are suspecting spontaneous bacterial peritonitis in a patient with cirrhosis and ascites. Now we come to the management of ascites. The initial treatment for cirrhotic ascites is restriction of sodium intake to 2 gram per day. When sodium restriction alone is inadequate to control ascites, we opt for the oral diuretics. Typically, the combination of spironolactone and furosemide. The aim is to achieve a weight loss of less than 0.5 kg per day, or sometimes it can be 1 kg per day whenever there is large amount of the peripheral edema present. Fluid restriction is traditionally been recommended in patients with cirrhosis and ascites who have hyponatremia. However, such an approach is not supported by available data. Fluid restriction is indicated only when the plasma sodium is less than 120 milliequivalent per liter. Among the diuretics, spironolactone and furosemide are usually used in a ratio of 100:40 milligram per day, and doses are titrated upward as required. Spironolactone is an aldosterone endogonist that inhibits the sodium resorption in the distal convoluted tubule of the kidney. Diuretics should be stopped if the patient develops uncontrolled or recurrent encephalopathy, if the serum sodium is less than 120 despite the fluid restriction, and serum creatinine is more than 2 milligram. So sometimes we start the diuretics in patients with ascites and cirrhosis, but usually we don't monitor that when to stop. So these are the things that we have to take into account, that we have to monitor the serum sodium, serum creatinine, and monitor the patient for the development of any signs of hepatic encephalopathy. Several medications should be avoided or used with caution in patients with ascites, particularly the ACE inhibitors, angiotensin II receptor blockers, and non-steroidal anti-inflammatory drugs. Apart from these symptomatic management, there should be management of underlying liver disease. In some cases, management of the underlying liver disease can treat the reversible components of a patient's hepatic decompensation and lead to the improvement or the resolution of the ascites. And this is particularly important in patients with alcohol-induced liver disease that has a very great amount of reversible component, and patient can improve with the removal of the alcohol. Then autoimmune hepatitis and chronic hepatitis B are such conditions in which patient can get benefit with the treatment of the underlying condition. But there are certain other causes of the cirrhosis which are not reversible, and it may be more appropriate to consider liver transplantation for definitive management in these diseases rather than the protracted medical therapy for the ascites. We have heard about the term that is refractory cirrhotic ascites. So what is it? It is defined by the persistence of ascites despite the sodium restriction and maximally used diuretic therapy. It can be maximal diuretic therapy or the maximally tolerated by the patient diuretic. Pharmacological therapy for the refractory ascites can include addition of midodrine, which is an alpha-1 adrenergic agonist, or clonidine, which is an alpha-2 adrenergic agonist, to the diuretic therapy. These agents, they act as vasoconstrictors, counteracting the splanchnic vasodilatation, which is seen in patients with liver disease. Midodrine alone or in combination with clonidine improves systemic hemodynamics and control of ascites over that obtained by the diuretic alone. So we can add these two drugs to the already taken diuretic therapy in such patients. When medical therapy alone is insufficient, refractory ascites can be managed by two other techniques, that is repeat large volume paracentesis. Patients undergoing large volume paracentesis should receive IV albumin infusions of around 6 to 8 gram of the albumin per liter of the ascitic fluid removed. Intravenous infusion of albumin accompanying the large volume paracentesis will decrease the risk of post-paracentesis circulatory dysfunction, and sometimes the death can also occur if we don't infuse albumin infusion in such patients. So in case of refractory ascites, when medical therapy is not working, we can go for the repeated large volume paracentesis done at periodic intervals along with albumin infusions. Then another mode is the transjugular intrahepatic peritoneal shunts, commonly known as TIPS. It is a radiologically placed portosystemic shunt to decompress the hepatic sinusoids. So the portal hypertension or the increase in the pressure in the hepatic sinusoids, which is there in patients with cirrhosis, is decompressed with the help of the transjugular intrahepatic peritoneal shunting. This is superior to the large volume paracentesis in reducing the accumulation of ascites, but it is associated with an increased frequency of hepatic encephalopathy. After the portal hypertensive ascites, we come to the management of other forms of the ascites, particularly the malignant ascites. So these kind of malignant ascites which are seen associated with the malignancies, they don't respond to the sodium restriction or diuretics because the pathophysiology of this type of ascites is different. So in such patients, they can undergo serial large volume paracentesis, transcutaneous drainage, catheter placement, or rarely a creation of a peritoneovenous shunts, in which there is a shunt from the abdominal cavity to the vena cava is put. Ascites caused by the tuberculous peritonitis is treated with the standard anti-tuberculosis therapy, and if timely therapy is given with ensuring the compliance of the treatment, the patients with tuberculous peritonitis will recover with this therapy itself. Non-cirrhotic ascites of other causes is treated by correction of the precipitating conditions. So we come to the summary points of our presentation. That is, ascites is a common complication of cirrhosis, and the most common cause of the ascites is liver diseases, followed by other causes. And there is a difference different in this etiology in the developing and the developed countries. The development of the ascites marks the onset of a worsened prognosis and increased mortality in patients with cirrhosis. Among the investigations which we do for diagnosing ascites, SAG is now the one of the most important investigation, which is done by taking out the ascitic fluid and the serum of the patient and taking out the albumin concentration and the gradient of these two. If it is more than 1.1, which indicates portal hypertension, the two most common causes will be cirrhosis or heart failure. Additional diagnostic tests can be ordered based on the clinical suspicion depending upon the case. Treatment of the ascites in cirrhosis should be focused on dietary sodium restriction and the use of diuretics. The 90% of the cases of ascites will be managed by these two things if they are done in an accurate manner. Other treatment options for the refractory ascites include optimization of the medical therapy, serial large volume therapeutic paracentesis with the use of intravenous albumin, then the shunting, that is TIPS in selective candidates, and finally the liver transplantation. So with this, I've summarized my today's presentation, in which there is abdominal swelling and particularly the ascites has been discussed. Any queries and questions are welcome.
Very nice presentation, Dr. Payal. If there are any queries, you can either ask, or what you can do is you can type in the chat box also.
Any query?
There is a query: how to treat refractory ascites uncontrolled on midodrine?
Yes. So as we have already discussed, that midodrine or clonidine can be added to the two other important ways of ascites control, that is our diuretic therapy and the salt restriction. But if not controlled by these two, we can have large volume paracentesis, which we can do frequently along with the albumin infusions, and then shunting, that is transhepatic shunt, can also be done in refractory ascites.
Another query is again on starting dose of midodrine and what is the maximum dose to which we can go, madam?
That will I will have to see. I will.
HRS AKI management. I think these are overlapping questions.
Management of spontaneous bacterial peritonitis, as it is caused by the bacteria which are coming from our bowels, and usually they are the E. coli Klebsiella. So initially we have to start with the cephalosporin, which cefotaxime is the preferred drug, and we have to give it without waiting for the report itself. The patient with ascites who is coming to us with the fever and the abdominal pain can be started on the prophylactic antibiotics, and with the confirmation of the cell count in the ascitic fluid, which is more than 250 cells, then we have to continue with the antibiotics and monitor the symptoms of the patient, and side by side we have to give the treatment of the underlying condition also. In cases of infection, usually we don't prefer the therapeutic tack. A question is there. Okay, this is TB peritonitis.
Yes.
Can we do? Yes, we can do a therapeutic tap in tuberculous peritonitis also if the patient is having massive ascites. But we usually don't prefer in all cases of tuberculous peritonitis. We usually prefer diagnostic tap in that cases.
Any other queries? How long midodrine should be given? See, midodrine, I think it is available as 5 milligram tablet, and you can give it per orally also, and twice or thrice a day, I suppose. You will need to see that if it is reversible hepatorenal syndrome, then obviously you can think of stopping it. But otherwise, these are all long-term therapies, and you will need to give it for a very long time. Any other queries?
For the
Yes, thank you,
SBP
Dr. Payal. I think
prophylaxis,
yes.
usually the patients who are having very low ascitic albumin, they can be given a prophylaxis for the SBP. It has been mentioned in the text that the patients who are having very low ascitic fluid albumin, they can be given for the SBP prophylaxis. Abdominal tuberculosis present as portal hypertension. So as per se, abdominal tuberculosis doesn't present as portal hypertension, but sometimes if there is it's associated with portal vein thrombosis or any other things which can lead to the hypertension in portal system, then only it can present as portal hypertension. Otherwise, it presents with the constitutional symptoms of tuberculosis, abdominal distension. Sometimes it can present as obstruction, subacute intestinal obstruction also. One question is hepatic encephalopathy after recovery, when to start diuretics? Okay. So usually we have to monitor the patients if the patient is admitted to us on the day-to-day basis, because whenever we are starting diuretics, we have to monitor electrolytes. We have to monitor whether patient is undergoing going into hepatic encephalopathy. So this will be usually a task which requires monitoring, and it has not been mentioned that after how many days of this hepatic encephalopathy. Usually, if we recover and the patient is requiring a treatment for the diuretics, we usually start the diuretics when the patient is out of encephalopathy. And again, because you know that it is a fluctuating course in some patients, sometimes it becomes difficult. And once we see the patient, the very next day, the patient is in altered sensorium or sometimes sleep in a grade 1 hepatic encephalopathy is there. So if you think that the patient is out of the hepatic encephalopathy, you can start the diuretics. But again, cautiously with the titration of the dose is required. And usually the single morning dose will be preferable. And also many a times in the wards, we are giving injectable furosemide. So that is not the first choice of the route of administration. Usually the furosemide is absorbed quite good in patients with cirrhosis also, and we can give as an oral formulation. So whenever you are starting diuretics, start as oral formulations only. Don't go for the injectables.
Any question? Anybody else? No? So thank you, Payal. Thank you very much.
Thank you, sir. Thank you, sir.
You have done marvelous job.
Thank you so much, sir.
Thank you, thank you, thank you.
Okay. Shall I leave then?
Yes, you can.
Okay, sir.
Thanks.